Hello, my name is Vladimir Maletic, and I'm a member of the Psych Congress Steering Committee. It is my great pleasure to welcome you to this session titled Addressing Inadequate Treatment Response in MDD, a Focus on Treatment Augmentation. This session is supported by an educational grant from Otska America Pharmaceutical Incorporated and Lundbeck. Now, let me introduce distinguished speakers for this session. They are Dr. Larry Culpepper, Professor of Family Medicine at Boston University School of Medicine in Boston, Massachusetts, and Dr. Michael Theis, Professor of Psychiatry, Perelman School of Medicine, University of Pennsylvania, and Corporal Michael C. Kresnitz, VA Medical Center in Philadelphia, Pennsylvania. At the end of this session, Dr. Theis and Dr. Culpepper will join us for a live Q&A. You can type your questions in the Q&A box to the right of your screen, as well as upvote questions submitted by other attendees. If you want to see their question answered, that would be the reason to upmark them. Our distinguished speakers will try to answer all of the most popular questions with the time remaining at the end. Without further delay, let us begin this session. Thank you.
Michael and I both have faculty disclosures that are displayed on this slide and the next. Today's objectives cover optimizing treatment of major depression, thinking about how we can minimize barriers to optimal care, and biological targets that can be used to improve the outcomes of treatment. My focus is going to be on the unrelenting burden of inadequate treatment response and non-pharmacologic approaches to improving treatment response. Let's start by hearing from Mary. She's a real patient who's agreed to share with us her history with antidepressants and the problems that can come from a mismatch between what the patient might be optimized on and treatments that they may be receiving in the interim.
Okay, where to begin? This year I turned 50. I was first diagnosed with depression in August of 1992. At that time, I was started on an antidepressant, and basically from 1992 to 2000, I did really well on it. In 2000, my father passed away, and the stress of that loss put me into a relapse. And at that time, I just felt like that antidepressant had stopped working. So at that time, my doctor decided to add an additional antidepressant that was new, and that pairing worked well. And it got to the point where I could drop the first initial antidepressant and just continue on with the second antidepressant, which I did. And again, was very functional, didn't have really any daily side effects with the new medication. In the spring of 2006, they introduced the generic form of that medication, and I was doing through work, they switched me to the generic, but at that time I also had a major relapse and I started to spiral downward, and I realized that there was something wrong, and I just wasn't responding to the generic. My doctor was able to get me back on the brand medication, and I did bounce back a little bit, but I was still struggling. And I had some new symptoms. I had some new anxiety and panic attacks that I had never had before. You know, we tried some anti-anxiety meds, and I didn't really respond well to them. And at that point, we started discussing adding some additional medications to what became known as my baseline brand med. And over the next 5 years, we tried 4 additional medications, and each one a new set of daily side effects and not really much added benefit. So I was giving them, not just like 6 or 8 weeks. I was giving them 6 months, some of them a year plus. The side effects went from annoying to like the dry mouth, the headaches, to the night sweats. I would wake up, drenched in sweat, to more significant side effects for me, which were, weight gain of almost, 35, 40 pounds with one of them. I had brain zaps. I had severe tremors. My hands would shake. My sister would, she lives in a different state, and I would see her, every couple months, and she'd be like, "Do your hands always shake like that?" And I'd be like, "Yeah, pretty much." Like, she's like, "That's awful." And I'm like, "Yeah." And, in addition, I had some sexual side effects that obviously were not great, and, made being in relationships more difficult. I also had, with one of them, severe and strange muscle weakness in my legs. I could run up steps fine, but I couldn't walk down steps. I'd have to like rip onto the handrail. It got to the point where like they were going to possibly do muscle testing on my legs, but then when they told me it involved sticking needles in my legs, I was like, okay, no, let's just try to wean off this medicine. So beginning of 2012, when I was just like, okay, I've had it. I've got to get off the last of the trial medications. And it took me probably 6 months to get off that last medication. And at that point, my doctor was just like, I don't know what else to try. And I was also at the point where I was like, I can't deal with any more side effects.
In my talk, I'm going to discuss real-world rates of response and remission, problems that arise in not attaining remission, and then look at some of the barriers, some of the non-pharmacologic barriers to attaining remission, and approaches that we can use to overcome them. When we look at the global burden of depression, what we find is that it's a disease of the young adult. Here we see that it's really in the ages of 20 to 24 and up through middle life, where we see the greatest impact on overall productivity and loss of life from depression. It's the most common disabling condition worldwide, with 70 million years of loss to disability and very high rates of suicide. Now, what we also know, given the current times, is that problems of depression and the consequences of depression particularly visit the poor in our society. This slide is from a number of years ago and looks at depression prevalence, stratified by socioeconomic group. What we also know is that major depression rates go way up following new episodes of global economic depression. And particularly people with financial strain or increased deprivation during economic depression are likely to develop major depression. So it's a disease that's more common in low-income individuals, but it also has the most profound effects and the most long-lasting effects in that group. Now, when we look at treatment challenges, what we find is a rather dismal record so far. If we look at patients that have major depression in the last 12 months, we find about half have received any treatment, and about half received no treatment. But of those that did receive treatment, what we find is that about 60% received inadequate treatment. In other words, they continue to have a burden of symptoms and impairments. And only about 40% received even the least minimally adequate treatment. And even among those, many did not attain full remission. So it's a major problem, not only in initiating treatment, but in getting patients to the optimal treatment for their symptom. Now, we also know that even patients who respond to treatment often have, in fact, the vast majority have residual symptoms, and that may occur even with attaining remission. This looks at the STAR-D study to start with, and we see that sleep disturbance and appetite and weight disturbances were the most common in STAR-D. When we look at another study with patients who attained remission with fluoxetine, what we find is that even attaining remission with fluoxetine left them with at least one residual symptom the majority of the time. And again, among these, sleep disturbances was the most common, although anxiety was also fairly common. Another study followed patients weekly for 3 years and investigated their symptom course. And what they found was that even during remission, patients continued to have symptoms. Cognitive problems, lack of energy, and sleeping problems dominated the course of depression and were frequent the vast majority of days during episodes of depression over those 3 years. And even between episodes of depression, about 40% of patients continued to have those symptoms. Now, the consequences of not reaching remission, depending on how you want to classify remission in your own practice, may affect these, but not reaching remission affects not only the disease course of major depression. We have higher risks of relapse, more frequent relapse, less time during any interval not depressed, more depressive episodes over time, with the result of increased overall mortality, both from suicide and from other medical comorbidities. That translates into higher indirect and direct costs. So direct medical costs, psychiatric costs, hospital costs, all increased. What we also find is a major toll on society as these patients work less effectively, and more likely rely on long-term disability benefits. Now, we've known for a long time, this is a classic slide from way back in 1995, that attaining not simply a treatment response, but full remission is quite important in terms of preventing early relapse. And so maintaining patients over time requires attaining remission. When we look again at the STAR-D study, what we find is on the right that a number of symptom clusters accounted for overall impairment, with sad mood, concentration, fatigue, loss of interest, all having high impact. The impact was slightly different depending on the area of function investigated. So certainly those who were having great difficulty at work, the most common symptom was early insomnia. Those with difficult relationship issues, self-blame was often the most common. Social activities were most impaired by loss of interest. And home management functional attainment was impaired most often by fatigue. Overall, though, what we see is that only those attaining full remission had a return of full function. This slide takes a deeper dive into the impact of inadequate response on work impairment. What you see here is if you focus on the left columns, the columns with 0 hours under them, what we see is that on the top, the hours missed from work. So 60% of individuals had missed no hours of work at baseline. But even after 12 weeks of treatment, that had climbed to only 80%. So 20% were still missing significant time at work. On the bottom, what we see is the hours impaired while at work. And again, what we start out with is only about 20% of employees who are suffering from major depression. At baseline, only about 20% were not impaired at work, had no hours of impairment at work. But even after 12 weeks, we still had more than 50% of individuals who were suffering from work impairment. Now, we can look at this data another way. The top here is looking at work loss, work productivity loss. And what we find is that when we break the treatment response into those experiencing early remission, those experiencing some change but minimal change, and then those with high impairment, what we find is it's early improvement that is quite predictive of long-term improvement in work productivity. So the top slide shows you the first 6 weeks, and then you can see in the bottom slide that even out to 28 weeks, those who had robust early improvement were the ones who ended up with much higher rates of remission and early return to full work activity. So let's look at experience in practice. Many patients with depression self-report as non-remitters, even though using HAM-D or other symptom scales, we would classify them as having attained remission. So that in one study here of 142 patients who had attained remission using a HAM-D scale of less than 7, 63 still did not consider themselves as having remitted. And when we look at that group of self-described non-remitters, even though their symptoms had in fact attained remission rates by our scales, still had greater functional impairment, had poor quality of life, and had decreased likelihood to be satisfied with their lives. The most frequent symptoms that they developed during treatment that were not present at baseline, but that had developed include problems with sleep, both mid-nocturnal and early morning awakening, changes in weight, hypersomnia, and decreased weight. So certainly those have major effect. But let's consider further what patients might consider important in determining remission. This slide provides a rather detailed look at factors that patients found very important and those that they found most important in defining remission for themselves. And what we see is overall out of this data is that they want a full, robust return to life as it used to be. They want to be their old normal self. They want to have a positive mental health outcome. They do want absence of symptoms, but they really want to feel back in control of themselves and in control of their ability to work, to be emotionally resilient, and to be able to function at work, at home, and school like they used to. They want a positive outcome on life. They want to feel like they're enjoying life. So these are the factors that patients feel are most important. Many of these are not reflected on the scales we use. So it is important to explore with patients how they're feeling about their treatment response and making sure that we take the cues about lack of remission from that discussion into account in considering further adjustments so that we do get patients back to full functioning and full enjoyment of life. Unfortunately, the reality still leaves much to be desired. So when we look at patients started on antidepressants, what we find is that over a 6-month time, only about 19%, took their medications according to standard guidelines. And a large group discontinued treatment, about half. Unfortunately, we may not know about that because about 90% of patients who discontinue treatment do not report that to their physician. So it leaves us in the dark in terms of the medications they have stopped. So it's very important to discuss this with patients and to make sure we're on the same wavelength in terms of patient adherence to treatment recommendations. When we look at the factors that contribute to non-adherence, certainly there are problems in dosing, in side effects from multiple medications, from having long treatment without response, as we saw earlier. We also have a number of disorder factors. So the chronicity of depression, its severity, and other comorbidities all may contribute to non-adherence, as do patient factors such as attitude, not being informed, not having an adequate understanding of depression, are having very low social support. So these are all factors. Most of these are things that we can do something about, either through other treatment or through more engagement with the patient. Let's look at factors that led to poor adherence to treatment during the 7 days before psychiatric hospital admission for major depression. What we find is that not being married had a major impact to decrease adherence. A number of other factors contributed as well. Certainly being suicidal contributed to not adhering to treatment. There are a few factors that improved adherence to treatment. So having a positive medication attitude contributed, was beneficial. Having few medication side effects was beneficial, but we see a number of factors that we can impact with our treatment, affecting a decreased adherence leading up to psychiatric hospital admission. We also see similar results in terms of poor antidepressant adherence and suicidality. So what we see is that decreased adherence with both SSRIs and SNRIs, not as strong with SNRIs, but with both, leading up to increased suicidality. Symptoms may result from our treatments as well as from the underlying major depression. Here we see that irritability, anxiety, insomnia, panic are all self-reported treatment-emergent symptoms that appeared with the start of new treatment. What we see, though, is that long-term, over 12 weeks, those whose treatment-emergent symptoms subsided or didn't worsen were much more likely to attain remission by 12 weeks, whereas those who had worsening treatment-emergent symptoms had poorer outcomes. Sleep disturbance is a particularly worrisome association with major depression. And here we see, particularly in the right bar, that patients that had some sleep disturbance going at the baseline of treatment for major depression and whose sleep disturbance worsened, or even those whose symptom disturbance did not improve, were much more likely to continue to have suicidal ideation. Whereas those who had lower sleep problems to start and whose sleep improved over time were the least likely to have problems with suicidal ideation. Now, let's look at what we can do about this. What we know is that when patients have strong preferences for treatment, be it antidepressant, or psychotherapy, if we offer them treatment that matches that, they are more likely to have improvement. And if we mismatch, in other words, they may prefer something strongly and we provide the alternative, they're much more likely not to complete treatment and not to attain remission. So it's important. It doesn't mean that we automatically go with the patient's preference, but we need to discuss it so that at the end of the day, the patient understands our rationale and comes to agree with it as the preferred treatment for them. A therapeutic alliance is also important. They need to trust. They need to trust us as we offer them therapy. This just describes that the stronger the therapeutic alliance, the more likely the patients are to attain remission. Some additional steps to improve patient adherence. One is to identify patients at risk, and that is those with high levels of symptoms, and particularly that underestimate symptom severity. People naive to major depression and to its treatment, so people in their first episodes. Those that do not have proper understanding of the disorder and its cause. So having a clear understanding of depression as a brain disease as opposed to a moral weakening, or a random event, all determine patient adherence. By offering frequent contact, we actually work through some of those issues with patients and provide them the support they need to initiate treatment. So in one study, this was a study actually in primary care, but in one study, patients were called 1 to 3 days after starting treatment, and only 3 questions were asked. Did you get the prescription filled? Did you take the first dose? And do you have any questions for us? And this was usually a practice assistant making the phone call. Took 3 to 4 minutes, but it markedly increased initial uptake of therapy. So in some cases, a 25% uptake in initiation of therapy. We also see that enhanced care programs can improve the outcomes. So here we see usual care compared to telephone management, where telephone contact is used to augment management, and then telephone management with some psychotherapy. And we see across the board that adding enhanced care components does improve treatment adequacy and patients' satisfaction and response. Now, we have known for a long time, this is data from back in 2001, and I use it because even though it's 20 years old, we still haven't fully implemented its indications. These are the studies that were used by the U.S. Preventive Services Task Force to initiate the recommendation for screening for major depression in primary care settings. And I'd point out that those that included studies where the systems included case management, patient education, and screening were ones that led to the improvement in patient status 6 months after treatment. An initial very important component is that even though these were primary care-based, effective practice systems all had the engagement of a psychiatrist or other advanced mental health professional as someone that the primary care team could turn to for guidance with particularly difficult patients. This could be anywhere from 20 to 50% of patient groups. So psychiatric engagement, including through primary care practice, can lead to improved outcomes in populations of patients. Now, we can also attain marked improvements by making sure that depression is not treated in isolation. And I think we all know that patients with medical comorbidities are much more likely to experience depression, And those with depression are much more likely to have medical comorbidities. So when we look at those with one comorbidity, depression doubles. When we look at those with two medical comorbidities, we find depression increases fourfold. But what we also find is that the same enumeration, the numbers of comorbidities, as comorbidities increase, the odds of attaining remission for depression decrease. So it's important for us to focus on not just the depression, but any associated medical comorbidities. And I say that because what we also know is that identifying and managing both, or having a team that manages both, is much more likely to lead to improved outcomes across the board for a patient. Now, while we've had data for at least the last 2 decades demonstrating that we can improve outcomes of depression in primary care by an organized collaborative care approach, we've also had, for 10 years now, data demonstrating that when we manage depression within the context of the patient's medical comorbidities and concurrently with management of those comorbidities, we find much better outcomes. So this is a 2010 report from the New England Journal of Medicine, and it compared studies using the best practice intervention focused on a single condition versus a new approach using targeting of all the conditions concurrently. And what we see is for depression, the best approach, the measurement-based care approach, similar to the STAR-D study and others, had an effect size of 0.25, and that's out of 37 collaborative depression trials sensitized. When we looked at the multi-morbidity collaborative care approach, that effect size increased to 0.65. And we also saw marked improvements in hemoglobin, systolic blood pressure, lipid levels, and significant cost savings. So what is measurement-based care? Well, this is the traditional approach of measurement-based care for major depression. We have a guideline that provides guidance for the team. This, again, is often in a primary care setting. We have a tracking system that allows us to make sure patients with major depression do not get lost. And it also allows us to track their improvement over time. We have a measurement tool so that we base our treatment changes on objective self-assessment of symptoms. And we have a care manager who helps us maintain contact with patients, may provide support in terms of measurement of symptoms and identifying any questions or side effects or concerns that the patients may have. Now, the transition from a single disease depression measurement-based care approach to this multi-comorbidity approach is really related to that tracking system. So what we want to do is burst it. So we do have the PHQ-9, but the hemoglobin A1C, blood pressure, statin, other conditions that we're going to manage concurrently are measured and displayed as well. What we find is that frequently it's simply gaining patients' return to adherence for those other treatment regimes, which has lapsed due to the depression, and then possibly adjusting their treatment as well. But when we do all of that adjustment concurrently, we get marked better outcomes. So in summary, what we see is that lack of attaining full remission, particularly remission as patients recognize it, is very frequent, leads to marked increased impairment, but that there are ways that we can identify it. There are ways that we can intervene with patients during the course of treatment to assure that our attainment of remission improves, and that particularly managing care, managing the individual as opposed to the single disease, can have a big impact, particularly for patients that are also enmeshed in a primary care system. Let me turn back over now to Michael to explore medication approaches to improving adherence and treatment outcomes.
Well, thanks, Larry. It's always a pleasure to work with you, and always learn from your lectures. And I'm delighted to be back with you all here at the U.S. Psych Congress. And the one thing I have to say is I look forward to meeting with you in person in 2021. But it is 2020, so let's start out and talk about the state of the art for outpatient treatment of major depressive disorder. And of course, our initial choice of treatment could be either pharmacotherapy or psychotherapy, or sometimes both. And patient preference and motivation have a lot to do with which one we pick first. Of course, depending on our care setting, we need to have capable psychotherapy available to us. Our particular favorite antidepressants, the same in Philadelphia or Boston or Ann Arbor, but the access to psychotherapy is a little more locally or regionally dependent. I favor pharmacotherapy over psychotherapy when severity is high or when there's urgency. I also favor combined treatment for those patients as well as patients with more chronic or complicated cases. I think importantly, everything we know from controlled studies suggests that these treatments are comparable over, say, 12 to 16 weeks, although pharmacotherapy tends to get people to a desired outcome a little bit faster, and that taking good care of our patients has much more to do with people getting better than the specific treatments that we pick. And so ultimately, whether it's psychotherapy or pharmacotherapy, see our patients frequently, spend time with them, remember their concerns, and provide adequate time to deliver the nonspecific elements of care. So let's talk a bit more about our antidepressants and what our unmet needs are at this moment in time. As I mentioned just a moment ago, the nonspecifics of care outweigh the specifics, but that 10 to 20% specific advantage is really important for 1 or 2 out of 10 patients. Just be prepared for the possibility that about 10% of patients will not be able to tolerate the medicine you pick first for them, that another 10 or 20% may be somewhat better but have persistent residual symptoms, as Larry talked about, including insomnia, anxiety, and cognition, and that all of our first and second line medications work through a multi-step process in the brain. I'll talk about that a little bit later, that requires several weeks, if not a little bit longer, to fully orchestrate. So they have a relatively slow onset of action. No matter which medication we pick first or second or even third, about a quarter of our patients just can't get better with what we have in hand as our first few lines of therapy, and they may require new interventions that work through different mechanisms. Some mechanisms may not have even been explored yet. I'll show you a slide about that in a little bit. So if you'll recall that the original discoveries of antidepressants coincided with the recognition that basic monoamines, and for depression, they were serotonin and norepinephrine primarily, these ancient neuromodulator systems were intimately important with how antidepressants worked. And you can see that serotonin and norepinephrine are co-localized in the brainstem, and that the tracks run together and innervate really important parts of the brain in terms of regulation of sleep and appetite, regulation of emotions, higher order pursuits, problem solving, and so forth. So for a long time, there was just the belief that, like Parkinson's disease, depression might be related to a deficiency of serotonin or norepinephrine. We now know that that's rarely true. And for the most part, we use antidepressants that modulate serotonin or norepinephrine because we know they work, and that these ancient neuromodulatory systems really do help to regulate or reset the stress response process that may be at the heart of why people get depressed. Now, as you know, it's not just reuptake inhibition that involves serotonin or norepinephrine or dopamine. And in the last 15 years, a whole new generation of treatments called atypical antipsychotics or newer generation antipsychotics have come to bear. And these medicines mostly also work through serotonin, norepinephrine, and now dopamine neurotransition, but they do so in a more indirect way involving modulation of various receptors. So these are mostly postsynaptic effects, so they can be complementary to the effects of the classic reuptake inhibitors. And I'll review the evidence for these newer generation antipsychotics as adjuncts to antidepressants in a little bit. But as you can hopefully see from this 36,000-foot overview of the various receptor effects that these medications have, there's a great range of diversity and complexity, and that one newer generation antipsychotic does not often have much relationship with another. So you've got different alternatives and different options here, probably even richer and more varied than the differences between particular reuptake inhibiting antidepressants. And now looking towards the future, we've known for the past 20 years that there are many, many elements of the stress response system that go over and above those of norepinephrine, dopamine, and serotonin. And I know you didn't come to today's talk to hear about the neurobiology of depression, more about the treatment, but I will simply say that when you come to like inflammatory processes or other ways of modulating the stress response, or yet other ways of restoring neuroplasticity, there truly are new mechanisms on the horizon to treat patients who may not be treatable with our current therapeutic strategies. And so I think as our understanding of the complexity of depression increases, so do the possibilities to get patients better. And with that in mind, let's look at the glutamate synapse, because here, this was 20 years ago, this was not suspected to be linked to depression, but lo and behold, there was the serendipitous discovery of ketamine having antidepressant effects, which then led to looking at the MDA receptor site first, and then other aspects of glutamatergic neurotransmission as potential opportunities for new antidepressant treatment strategies. And in 2019, one of the first practical approaches to using this target was approved by the FDA for treatment of depression. I'll come back to that towards the end of this talk. In general, when we follow algorithm-guided care, which is one of the implications of this depression care management that Larry described, we want to see people frequently follow their response, change when the treatment's not working or it's poorly tolerated. We have a hierarchy that goes from our favorite and easiest to use, less expensive, generically available antidepressants. In most parts of the country today, that's an SSRI, sometimes an SNRI, sometimes bupropion, occasionally mirtazapine. But we go from a first-line strategy, typically to an alternate other first-line strategy in the second tier of this algorithm. Sometimes, after 2 trials, we may be using newer generation antipsychotics as adjuncts, or we might even switch to one of the older antidepressants, a tricyclic or an MAOI. Data I see on pharmacy use suggests that adjunctive and combination approaches by far outweigh the use of tricyclics and monoamine oxidase inhibitors in 2020. Most of us use neuromodulation strategies in a 3rd or 4th or 5th line sequence. Electroconvulsive therapy's got a stronger effectiveness portfolio or profile than TMS, but TMS is much more tolerable and easier to implement on an outpatient basis. And then now we can add intranasal esketamine, which was approved as an adjunctive treatment for patients with treatment-resistant depression by the FDA in 2019. And of course, the generic intravenous comparable to intranasal esketamine, and that is racemic ketamine at about a quarter of the usual anesthetic dose. Now, beyond that, there are other treatments on the horizon, other treatments being reevaluated, including a reconsideration of whether vagus nerve stimulation might be a more reimbursable, useful treatment for patients who have exhausted other treatment alternatives. I think one of the things we learned from STAR-D, we hadn't set out to learn, was that you have the best chance of getting patients better in the first 6 months that you're treating them. And whether you're choosing an augmenting strategy or a monotherapy strategy, with each unsuccessful treatment trial, the chances that the next pharmacotherapy will work go down. And this is mediated by the lack of effect on the core symptoms of depression, as you can see on the right. And in essence, this may be because most of our treatments work through monoamine systems. So we may be exhausting the patient's capacity to use these kinds of treatments, and our need to go to dissimilar and perhaps novel strategies may increase progressively as the number of unsuccessful treatments mount. So let's think about what we do when our first choice of treatment doesn't work. Importantly, as Larry emphasized, has the patient really taken the medicine? Could the patient have another problem that we missed the first time around? Could they be drinking too much or using other drugs in a problematic way? Could there be, as of yet, unrecognized medical illness? Let's also reconsider the diagnosis. Could they have bipolar disorder? Could there be psychotic symptoms not yet recognized? Could they have another condition that has depression as a comorbid accompanier, PTSD or OCD, or common examples of that? Lastly, maybe they're treatable. We just picked the wrong medicine. And so if the answer to all of the above is no, try a completely different antidepressant. And always, since psychotherapy and other kinds of practical behaviorally activating interventions are useful alternatives, we should think about whether adding or switching to a behavioral intervention would make the most sense for this particular patient. I just bring this study up. I'm a co-author, but more importantly, we found in a study of chronic depression that the patients who had a history of childhood trauma, which can create PTSD, which can increase the risk of having a personality disorder, increasing the risk of having complicating substance abuse, that when patients had a history of early trauma, they were much less likely to respond to pharmacotherapy alone than they were to either psychotherapy or combined treatment. This is one example of differential therapeutics where knowing the person's story makes a difference in terms of what is likely to work. I think, as I mentioned a moment ago, that when you are moving along in the treatment process, think about strategies that help the patient get more active, get more engaged, be more of a participant in the things that make life worth living and make life worthwhile. Here's a meta-analysis of studies looking at simple aerobic exercise. And here we're talking about only, say, 10 or 15 minutes a few times a week of relatively light aerobic exercise. But for patients who do more exercise, the treatment tends to be even more effective. At the end of the day, you will see that your patients who are starting to get moving have a better chance of getting better than those who stay in the dark, in the house, on the couch. And the form of psychotherapy that's been developed that is the closest to exercise is actually called behavioral activation. And you can use exercise as part of a behavioral activation plan, but other parts of behavioral activation include making a problem-solving list and getting to work on it, making assignments or strategies to get together with people that get you, that care about you, that you've enjoyed being with in the past, trying to spend more of your time engaged and not isolated. It turns out when you're alone in the dark, the only person you're really talking to is yourself, and you know all of your dark secrets and dark stories. And when you have a monologue with a depressed person, when you're only talking with yourself, there's only really one outcome that comes from that, and that is feeling worse over the course of the time that monologue is in motion. Well, let's say we've tried psychotherapy, it didn't help. We need to move on. Do we want to switch the antidepressant or use an adjunctive strategy? And I think if the treatment is of almost no use or it's poorly tolerated, then obviously parsimony favors switching. It really is better to do one thing well. And however, if there's been some benefit with the first treatment and the patient is urgent to feel better, the adjunctive approach or combining approach really avoids the washout and cross titration and allows you to capitalize or retain the benefit of that first treatment. And I speak very highly and positively of our STAR-D study in many different circumstances, but today I'll simply say that we made an error in designing the study that we didn't realize at the time, and as a result of that, STAR-D didn't definitively answer the question about whether it's better to switch or use an adjunctive strategy. Nevertheless, when you look at the outcome results, you will see that to your eyes, the advantage clearly favored at each level along the way, clearly favored the adjunctive strategy, about a 10% advantage across each level of comparison, as you see here. Now, the reason I say this is an optical advantage and not a certainty is because the patients in STAR-D who got the adjunctive strategies were improving more and had better tolerability, fewer side effects than the patients who got the switching strategies. And that's the hidden mistake we made in designing the study. That's a confound that patients who were doing better and were hardier in terms of tolerating the antidepressant were selectively the ones who got to have the adjunctive strategy. And that's why we couldn't, at the end of the day, say for a fact. It wasn't the result of a truly randomized comparison, but one with an inherent important confound. Now, that said, I favor adjunctive strategies when the first therapy has been somewhat helpful and that it is well tolerated. And I can know about drug-drug interactions. I can work around that, so I'm not that worried about it. And our newer medications are so much safer than the older ones that we can often craft combination medications that match different aspects of the patient's depressive syndrome. Now, here's just one example. Azopicolone is not an antidepressant medication. It's a GABA-selective sedative hypnotic. But here's a study in which patients who had persistent insomnia received adjunctive azopicolone therapy, and lo and behold, it facilitated their early response and overall improvement during the first 4 to 6 weeks of treatment. So it accelerated the time to benefit. So let's talk about other combination and adjunctive treatment strategies and start with just a simple definitional explanation about what's a combination and what's an adjunct. I favor the use of the term combination when we're talking about two antidepressants. I favor the use of an adjunct when we're talking about the second medicine that is not an antidepressant, that is being added to enhance the effect of the first medicine, which is an antidepressant. About 10 years ago, the FDA asked us to stop using the term augmentation for these adjunctive strategies because we didn't always know if they were augmenting the mechanism or simply providing symptomatic relief through a different mode of action. And I'm sorry for this background noise. I can't fix it. Bear with me, please. So combination strategy would be when you're using two antidepressants. Adjunctive strategy when you have a non-antidepressant being added to an unsuccessful, but, well, not completely successful, but reasonably well tolerated first antidepressant. So combining antidepressants is becoming increasingly popular because of the safety of the newer generation antidepressants. 30 years ago, it was problematic to try to combine a tricyclic and an MAOI. We have so many additional possibilities today of medicines that combine. Here you see a meta-analysis of studies of combination therapy, and the particular combinations that seem to be valuable are adding a medication that has some secondary effects on serotonin 2 or perhaps alpha adrenergic neurotransmission, and these are the medicines that have more reliably been shown to work in studies of combination therapy. And here the best example would be adding mirtazapine to an SSRI or an SNRI. I know we love to add bupropion to SSRIs, and that indeed has clinical advantage to my eye, but in this meta-analysis, that strategy just didn't quite turn out to have a significant across-the-board benefit. I want to make a point with this slide, which compares on your left a relatively small study with very careful execution of both of the medications in a combined treatment approach, and on your right, a large kind of hurly-burly study with 50 providers across the country and I think 15 different sites or something like that. And if you look at the left, you'll say, wow, combined treatment is a really useful thing to do. If you look on your right, you will say, whoa, combined treatment doesn't offer anything other than maybe extra side effects. And so I think the answer may be somewhere in between. But if you learn anything from this, I think if you're going to do an antidepressant combination, try to make sure that the patient gets adequate exposure to both drugs in the combination. There are relatively few drug-drug interactions that enhance the blood level of the second medication, that if you're adding that second medication for its antidepressant effects, make sure you use an antidepressant dose and that the patient gets adequate exposure to both elements in the treatment combination. So let's now talk about some of our most commonly used adjunctive strategies. We've got older options like lithium and thyroid hormone, medicines that come from other areas of medicine, the folic acid derivative, L-methylfolate, medicines that are used to treat anxiety disorders primarily, such as buspirone and the benzodiazepines, and then, of course, psychostimulants, along with newer generation antipsychotics, which I mentioned at the outset. I'm not going to go into each of these in detail for the sake of time, but I do want to make a point that of all these adjunctive strategies, lithium is the best proven but least used adjunctive approach in 2020. Now, this may be because it was a better strategy for people taking tricyclics and MAOIs than it is now for people taking SSRIs. That's a possibility. It may be a fad in the sense that lithium has more broadly fallen out of favor, particularly for non-specialists, non-mood disorder specialists. It's really hard to know, but what I do know is that in STAR-D, another simpler strategy, adding thyroid hormone, was far easier for our docs to implement. If you are going to do it, you go low on your lithium level. Don't try to go above a 0.8 milliequivalents level. Keep in mind that there are some really bona fide, real good reasons to use lithium as an adjunctive strategy, including the patient has relatives with bipolar disorder. Their illness may be within the bipolar spectrum. And for both relapse prevention and reduction of suicidal behavior, there are true advantages for adjunctive lithium therapy. I'll show you a slide a little bit later on that demonstrates that this inexpensive treatment holds its own when it's compared in the modern era to newer generation antipsychotics. Here's a meta-analysis. It really does work, despite our lack of enthusiasm for using it in 2020. Lithium augmentation is an effective strategy, at least in an era in which patients were predominantly receiving tricyclics and MAOIs. The other old strategy that I think there still is a place for is using thyroid hormone as an adjunct. And here, I think it's important to keep in mind that we prefer T3 over T4 because T3 is the thyroid that is relevant to the brain. We typically use either 25 or 50 micrograms of T3 when we're supplementing, and it really is critical not to oversuppress TSH during this treatment. We are not trying to make the brain hyperthyroid. We are simply trying to bring the patient up to the tip top of the range of thyroid tone. Now, this is my treatment of choice when patients have a slight elevation of the TSH level, and I think if the patient has a history of treated hypothyroidism, I will also preferentially use this strategy. I think historically results have been better in studies that have been about depression in women or have had a majority of women participants than in studies that had a fairly large number of men. Here's that STAR-D study I mentioned a bit ago. You can see thyroid on your right, and lithium on your left. There was about a 10% advantage in symptom improvement with the thyroid augmentation group, and the more than twice as many people were able to complete therapy on thyroid hormone as did on lithium. So it was easier to implement, and the results tended to go better. Now, more often in the modern era, instead of lithium or thyroid, patients are receiving newer generation antipsychotics, and these have become the most intensive and best proven strategy for use with newer generation antidepressants. And this isn't just treating psychotic depression or even depressions that you think they're in the bipolar spectrum. These medications appear to have real antidepressant effects, and they've mostly been studied in combination with antidepressants. So at this moment, quetiapine, aripiprazole, brexpiprazole are FDA approved for a range of antidepressants, and olanzapine is approved in combination with fluoxetine. There's also evidence that risperidone, cariprazine, and perhaps even pimavanserin may have adjunctive antidepressant effects, although none of these other newer generation antipsychotics have been approved by the FDA. So I think critically, as I showed you at the receptor slide early on, these medications have important differences in their side effect profiles that are directly related to their different receptor effects. And so if you run into trouble with one, pick a dissimilar one within the proven within the group of proven medications, because they are not so closely related to each other. Now, some remaining concerns include the optimal duration of therapy and whether they're truly cost effective, although I'll point out that once a newer generation antipsychotic goes off patent, by the second or third year as a generically available medicine, the cost effectiveness question is greatly improved. Now, finally, all of these medicines have a lower risk of causing tardive dyskinesia than first generation counterparts, and it doesn't mean they have no risk. And in our long-term study of aripiprazole, 500 patients plus out over a year, we did observe several cases of new onset tardive dyskinesia. Now, fortunately, these cases were reversible, but if, of course, if the antipsychotic treatment continued without paying attention to the onset of new dyskinetic movements, it may become irreversible. So a low risk is not the same thing as no risk. Here's a little summary of the different medications that are available that have been FDA approved. As I mentioned, they get to FDA approval because of at least 2 positive studies, and each of these drugs has at least 2 positive studies, placebo-controlled. You can see that the effect sizes are pretty comparable across the group of medications. So there's no real advantage to picking one over the other from a standpoint of benefit. You pick based on matching the patient and the possibility of side effects. In the VA, we did a very large active controlled study with bupropion as the active control, bupropion switch, bupropion augment, and as you can see, aripiprazole augmentation group had a substantially better remission rate, or this is a slide of response rate, actually, substantially faster and overall higher chance of benefit than did the other 2 groups. Here are the data on brexpiprazole, which had not been included in that original meta-analysis. You can see that brexpiprazole has an effect very, very similar to that of the other agents in this group. Brexpiprazole, of course, was synthesized to remedy some of the side effect issues associated with aripiprazole. So these are the unresolved questions about the newer generation antipsychotics. I think importantly, when they work, we don't really know empirically how long they should be continued. So we recommend that after a few months, we try to taper, see if the patient can maintain their response. Often the tapering results in a symptom exacerbation and we need to go longer. And so longer means greater risk of tardive dyskinesia, and also more likelihood of metabolic side effects, weight gain, trouble with glucose regulation, and so forth. I think importantly, we've not really proven that people who can't sleep or have too anxious do better on more sedating ones, and patients who are anergic or who have low motivation do better on the non-sedating ones. But that's how I practice, and I think there is some room for clinical common sense as well. Now, the newest adjunctive therapy approved by the FDA capitalizes on those observations that I mentioned earlier about the antidepressant effects of sub-anesthetic doses of ketamine. And in the 20 or so years since those antidepressant effects were first observed serendipitously, we've had increasing confidence that intravenous ketamine has a large and rapid antidepressant effect for 40 to 60% of patients with difficult to treat depression. And as a result of that, one of the stereoisomers of ketamine, which is a racemic drug, the S stereoisomer, S-ketamine, has now been approved by the FDA for adjunctive treatment of treatment-resistant depression. The antidepressant dose of ketamine is typically about a 0.5 milligram per kilogram of body weight. Again, that's about 1/4 of the anesthetic dose for this. The parallel dose for S-ketamine is 84 milligrams. That isn't exactly the same thing as 0.5 milligrams per kilogram, and intranasal use doesn't have quite the same bioavailability that intravenous use has, but that is the kind of dose that we target for when we're using intranasal S-ketamine. In addition to the original approval in 2019 for adjunctive therapy of treatment-resistant depression, just last month the FDA approved S-ketamine as an adjunctive inpatient treatment for patients with major depressive disorder with suicidal ideation. So MDD-SI would be the acronym for that subcondition. I think importantly, there's been some talk that not all the studies of S-ketamine were positive and so on and so forth. These are the original 3 studies, and these are the week 4 endpoints, the Montgomery-Åsberg, which was the primary endpoint, the Sheehan disability, and the PHQ-9 self-report secondary endpoints. And I'll just leave it to you to say if you see a consistent effect across studies or not. Obviously, the FDA saw that consistent effect and did approve S-ketamine on the basis of one unequivocally positive acute study, one unequivocally positive relapse prevention study, and a lot of other supporting information. There are some considerations to keep in mind with S-ketamine as an adjunctive therapy. Of course, it is a Schedule III controlled substance, and its use and access is very carefully limited in the United States through a risk evaluation and mitigation strategy that prevents patients from actually possessing the drug. You can't buy it at drugstores. Healthcare systems buy and deliver this treatment. So the patient's not possessing it, so adolescents can't go into the drug cabinet at home and the medicine chest at home and have access to mom or dad's S-ketamine. I think it's a dissociative anesthetic. And so some patients will have dissociation. Some patients will also experience a transient increase in pulse or blood pressure. But importantly, about 94 out of 100 patients tolerated the 4-week course of this adjunctive therapy during the phase 3 clinical trial. So it is a reasonably well-tolerated adjunctive treatment strategy. Now, it is a controlled substance, and since the registration studies excluded patients who were known to be drug abusers and taking concurrent opiates, we do have real worries about how this treatment will or won't work, or what might be associated when we do treat patients who have more extensive substance abuse histories. So I say that issue is still open to consideration and open to a discussion. Now we're going to go ahead and take a look at Mary, and Mary is my patient, and I get the privilege of introducing Mary's story after she finally got effectively treated. So let's hear what Mary has to say about her subsequent treatment.
At the beginning of 2016, I kind of started to notice a decline and just more increase in symptoms. I was getting more anxious, just feeling more stressed. I wasn't doing as well. And again, I was feeling like my medication was starting to slip again. And by the end of that year, in December, I just was in a lot of despair. I just felt like I was heading for another major breakdown. You know, I was afraid to try new medicines because nothing had worked in the past, and I was just kind of at my wit's end. I was freaking out, and I went online, and I live in Philadelphia, and I went on to Penn's site, and I was just going to kind of go make an appointment to see a psychiatrist there, and then I found that they were looking for participants for a new clinical trial and for a new medication. It was a new treatment, and I basically filled out the web form, and 24 hours later, they followed up and called me and said that, you know, they wanted to bring me in. And I think it was basically the beginning of January, I began the screening process for the clinical trial, and I was accepted, and I received my first treatment in March of that year. So March of 2017, received my first treatment, and it was life-changing. So I started in the double-blind study, then basically I rolled over into the open label, and now I'm in the long-term safety study. And the response to the treatments is immediate. I could be having a good week, or I could be having a really bad week. And if I'm having a good week, then when I go for my treatment, it allows me to then build upon the progress of the week before. If I am having a particularly bad week, and I just knew that it was not going to get any worse, and that was like a relief, because I knew I was not going to feel worse than when I went in. I knew that there was always going to be a forward progression. You know, so right now, I would say, you know, on a scale of 1 to 100, I'm in the range of like 85 to 98%. There may have been days when I've gotten to 100%, but, you know, my depression's always there. And I know that I'm going to have, and I'm going to continue to have ups and downs. But I know that with like the treatment plan that I'm on right now, with my baseline med, this weekly treatment, and then I'm actually also doing weekly talk therapy, all three of those together, are helping me to survive. But I feel like it's slowly progressing forward. I never feel that completely hopeless feeling like that nothing's working anymore. Because like I feel like this is working.
And thanks to Mary for making these recordings to help bring our presentations today to life. Let me summarize simply by saying that the depression's got really profound personal and societal burdens. And we can do the best we can to remedy these by promptly recognizing and collaboratively engaging our patient in a treatment relationship that includes monitoring prospectively and ensuring adherence. And Larry did a really nice job demonstrating just how important these kinds of interventions can be. Similarly, looking at the whole person and addressing not just their depression, but any important medical or psychiatric comorbidities.
So at this point, I would like to thank again Dr. Stace and Culpepper for an excellent presentation. And here are some of the questions that we have received from the audience. So starting with, first question is regarding correlation between the number of years that MDD has been untreated and how might it influence a poor long-term outcome and likelihood of achieving remission. Would you care to take that one, Dr. Thace?
Well, sure. We know from our studies of chronic depression that even when people have been depressed for 5 years or 10 years, that when you treat effectively, that individuals can begin to feel better and function better within a matter of weeks. And so the good news is that the chronicity doesn't prevent the possibility of being effectively treated. I think it is fair to say, however, that the longer you've been ill, the more damage the illness does to your life, to your relationships, to your work history, and so forth. So whatever your portfolio, your combination of assets and strengths and skills and such may have been, it's probably been diminished by those years of depression. We know from Shalene's study of years of depression in terms of changes in different brain regions that also there is some damage, some wear and tear that's done to brain stress response systems by sustained unresolved depression. For example, in her most famous paper, Shalene found that hippocampal size was actually reduced in relation to years spent depressed, and years spent treated actually counteracted that effect. So I think there is both good news and bad news. Let's focus on the good news because you can't turn back the time of chronic illness, but you can recognize and treat effectively, and that is the best way forward.
Would you have any additional comments, Dr. Culpepper?
Sure. Untreated depression is a major factor in lack of adherence across the board to treatment of what we know are very frequent comorbid conditions. So we also accumulate years of untreated hypertension, diabetes, or inadequately treated other conditions, and that I think compounds the impact. I think the other thing that is still in the realm of uncertainty is whether untreated depression might contribute long-term to the development of dementia, Alzheimer's. There's certainly an element of untreated hypertension and vascular dementia that may be involved, but that's also a possible long-term consequence.
Another question regarding long-term management of MDD. This is a scenario that we do encounter occasionally. Patient has been successfully treated with an antidepressant, has been in remission for years, and now they have relapsed. Does this indicate that the patient's not likely to respond to that antidepressant in the future? With the dosage adjustment, should we switch or augment in that scenario? Either one of you.
Well, Larry, you get to go first this time, and I'll go second, okay?
Okay.
You handle it in primary care.
Yeah, well, first thing I'd do is check adherence. I mean, people that have been on long-term medicines often decide, maybe I don't really need it, and I'd rather use the copay to buy groceries. So, that's obviously a first issue. Second is what's happening in terms of stresses in the individual's life. Well, we know that recurrence, tends to become autonomous and unlinked from stress over, many repeated episodes. It's also a question. So, what's happening? So getting a little history to start out with is quite useful. So, patient now on his or her own, or major life changes and taking up. Substance use, there's just a lot of possibilities. So first off, I would consider, are we really dealing with simple, relapse or recurrence, or are we dealing with a more complex situation? If it is a situation that the patient has come off the medication that they had once found effective, then I think the answer is very simple. You restart the medicine that was previously effective. But if the patient is religiously on medication and that hasn't changed, then I think we're back at thinking about augmentation, switching, and that's where I would defer to Michael for a definitive answer.
In our long-term study of imipramine maintenance therapy of recurrent depression at the University of Pittsburgh, the only variable that explained drug failure during long-term treatment was inconsistent blood levels. And now, with imipramine, you could measure those. And of course, with the newer generation antidepressants, we don't do that anymore. And so that inconsistency in the blood level reflected intermittent non-adherence. No doubt about it. So let's assume that our patient says, I've been adherent, and then I'm thinking, I don't really believe in the concept of tachyphylaxis. I think that either my patient's illness changed, or maybe the medicine never really worked the way I thought it did in the first place, and then my patient got better because of a better prognosis, or because of the support I provided, or because of a marital reconciliation, or a new boss, or some other issue helped them recover the first time around, rather than positing that the brain has had a maladaptive change to sustained drug exposure. We see placebo showing the same kind of occasional failure in long-term studies, and nobody posits that the brain has become tachyphylactic to placebo response. So I do think you might have to change the medicine if you're confident that the patient has been adherent. But like Larry, I say look for non-adherence first, and do it in a positive, upbeat, collaborative way, not like you're an inquisitor trying to catch the person at something.
You have politely asked me to avoid political questions at the beginning of the talk. Here's one that could be remotely political, or definitely involving pharmacoeconomics. So the question is about the sequence of antidepressant interventions. Our audience member is pointing out that RTMS is indicated after a failure of an antidepressant. So why have to go through 3 or 4? And this is based on some of the guidelines and also insurance company policies. Why have to go through 3 or 4 antidepressants and atypical antipsychotics before one can consider RTMS when the balance of efficacy and safety is very favorable?
RTMS has a wonderful safety profile. Its efficacy profile is comparable to that of any of your favorite second-line antidepressants. And so from a benefit and safety standpoint, it could easily be considered a first switch or augmentation option. However, it costs about $200 a treatment, and you need to have about 20 treatments to know whether it's going to work or not. And so you're talking about, if I do the math right, a $4,000 treatment, as opposed to, a generic trial of mirtazapine or venlafaxine at Walmart prices, a $50 treatment for the same amount of time. Now, of course, they're doctors and so forth, so a $200 treatment. So these are judgments that society makes, and most of our insurance coverage, including mine, I think, would not permit me to go to RTMS until I had at least 2 or 3 different treatment trials. And our questioner correctly notes that TMS is less effective after 3 treatment trials than after 1. So this seems paradoxical. But the way we're living our lives now, you can't have the $4,000 treatment unless you've gone through a few of the $200 treatments.
Yeah, we probably also don't have quite as much evidence of long-term use and how we maintain patients over the long term. How you would transfer this patient into the first patient you gave us, the patients that had been on therapy a long time.
And there are access issues too. That in certain parts of the country, you just can't get to TMS, whereas these second-line favored antidepressants are available all over.
Well, I wish to thank again Dr. Stace and Culpepper, not only for their wonderful presentation, but also for very informative and entertaining Q&A session.